We have all read the tragic headlines. In February 2026, 29-year-old Charles Inisa, victim of a hit and run, died after being turned away by 3 hospitals. Back in 2018, 70-year-old Prince Anthony Opoku Echampo met the exact same fate after being rejected by 7 different hospitals. Both lives were lost because the hospitals simply had no beds. This crisis has been universally labeled the NoBed Syndrome. But what if we told you that buying more beds will not solve the problem? What if we showed you that the NoBed Syndrome is merely a visible symptom of a much deeper, invisible crisis paralyzing Ghana's healthcare system? It is tempting to think the solution is simple. Just buy more beds or build more hospitals. But to understand why that alone won't work, we have to look at how Ghana's healthcare system was actually designed to function. By design, the system is a highly structured, tiered referral network. At the base is the primary level, consisting of CHIPS compounds, health centers, polyclinics, and district hospitals. These act as the first line of defense, filtering and managing minor ailments and basic emergencies. And if a case becomes too complex, it is then referred to the secondary level. Here, regional hospitals step in to provide specialized care and advanced clinical techniques that exceed the capabilities of the primary centers. Finally, at the very peak is the tertiary level, where teaching hospitals fall. They are equipped with high-level technology and expertise required for the most critical, life-threatening cases. By operating in this strict step-by-step order, the teaching hospitals are protected from being overwhelmed. But the reality on the ground looks very different. When the foundation is starved of resources, the top tier drowns in patients. A terminal mix of systemic failures has completely paralyzed this arrangement, causing the hierarchy to collapse from the bottom up. Let's look at the data to see where the cracks begin. Those cracks start at the very foundation, the frontlines, the nurses and doctors who receive patients. Data reveals that these human frontlines are critically understaffed. According to an empirical study by Afrifa Yamwine colleagues, over 70% of primary health facilities completely lack the specialized personnel required to handle emergency and critical care. In fact, a whopping 92% of personnel in charge at these clinics cannot execute basic CPR. But here is the tragic paradox. While these facilities are severely understaffed and the remaining workers are suffering extreme burnout, thousands of trained nurses sit unemployed at home, paralyzed by the government's inability to secure financial clearance to hire them. Faced with this systemic neglect, poor working conditions, and low pay, our medical professionals are choosing a highly rational yet devastating response. They are migrating to high-income countries in search of better conditions. Yet, employing enough healthcare workers is only the first hurdle. Even when facilities are adequately staffed, healthcare workers are severely restricted by a lack of functional tools. At the primary care level, Facilities are routinely starved of emergency oxygen, basic medications, and functional tools. And this equipment crisis doesn't stop at the primary level. Even at our major tertiary hospitals, the facilities we believe to be our ultimate safety nets, the tools are failing. In March 2022, 42-year-old Kwame Ado was receiving life-saving treatment at the Komfo Anokye Teaching Hospital. Mid-therapy, his dialysis machine suddenly failed. The backup unit was unavailable because of chronic maintenance issues and a lack of spare parts. Kwame did not survive. His tragic death exposes a silent epidemic. A 2025 study by our Samoa and colleagues reveals that a staggering 40% of vital equipment, including ventilators, MRI scanners, and dialysis machines, sit completely inoperable at any given time across our regional and tertiary hospitals due to chronic maintenance failures. We don't just have a shortage of physical beds, we have a graveyard of broken life-saving machines. And when the primary facilities are understaffed and machines are either broken or non-existent, a patient's only hope is to be seamlessly transferred to somewhere that can help. In a functional system, hospitals should coordinate through real-time national bed tracking networks. Ghana attempted to build this, investing heavily in the Lightmove Health Information Management System in 2019. The ambitious goal was to digitally connect 950 health facilities so doctors can instantly locate available beds nationwide. However, this digital lifeline became mired in severe delays, scope changes, and disputes, ultimately leading to its replacement with the Ghana Health Information Management System, which is still being rolled out. Without a functional network, ambulances carrying critical patients and desperate families are forced to physically hop from one hospital gate to another, hoping to secure admission before time runs out. And when the public realizes that the primary facilities lack staff, machines are broken, and the referral system is a dead end, they make the only logical choice left to survive. They bypass the primary and sometimes secondary facilities entirely, presenting directly to our major tertiary hospitals for conditions that could and should have been managed at the lower levels. This mass bypass creates a catastrophic bottleneck at the highest level of care. Specialized teaching hospitals, which were designed strictly for complex, life-threatening emergencies, are suddenly consumed by a flood of basic primary care needs. This is a true anatomy of the NoBed Syndrome. The severe congestion we see in the headlines, where exhausted doctors are forced to treat patients on plastic chairs or on the floor, is not just a lack of furniture. It is the visible manifestation of a deeply fragmented referral system. It proves exactly what we established at the beginning. When the foundation is starved of resources, the top tier drowns in patients. This forces us to look at the root of the problem. Behind this clinical collapse is a massive governance and funding crisis. At the operational level, the National Health Insurance Scheme suffers from chronic delays in claims payments from government. This creates a massive buildup of arrears that cripples facilities, leaving them unable to buy medicine or fix broken machines. It is also the exact reason why the government cannot secure financial clearance to hire those thousands of unemployed nurses. But the data reveals a much deeper vulnerability in procurement. According to a 2025 IMM Diagnostic Report, over 40% of public procurement relies on sole sourcing, exposing the system to severe mismanagement. Consider the Agenda 111 project, an initiative specifically designed to build new hospitals. A 2025 Auditor General report revealed that 35 contractors had to be surcharged to refund $7.9 million. Why? Because they received their mobilization fees and completely abandoned the construction sites. Furthermore, collusive financial practices and abrogated contracts have cost the state approximately $358 million in judgment debts. That is hundreds of millions of dollars meant to save lives, lost to official negligence. These financial and governance failures are the root causes of the clinical collapse we see every day. So identifying the root cause also gives us the exact blueprint for the cure. Buying 1,000 new beds won't save us. A bed is useless without an energized nurse to staff it, medication to treat the patient, a machine to monitor them, and a digital system to coordinate it all. 1,000 new beds in Kolebu won't fix the crisis if the smaller clinics surrounding it remain completely unequipped, forcing every patient to bypass them. To cure this, we must aggressively equip our primary health facilities to win back the public's trust. We must establish an integrated digital national referral system to optimize patient flow. We must also retain our brilliant medical minds with timely pay and better conditions. And we must prioritize equipment maintenance. It is time to fix the entire ecosystem, not just the furniture. This has been a Phoenix Insights Data Story. Thank you for watching till the end. Don't forget to like this video, comment, and subscribe. See you in our next one.